The sensor wants to see a certain threshold amount of light or radiation. And if you put something in front of that sensor, it doesn't see that amount of light. So it'll actually keep exposing longer until it reaches that threshold. We sort of reasoned that the shields might actually be contributing to higher doses because they could be blocking that sensor in the X-ray machine. So that's really what's prompted the research that we did, was that idea, that theory that the gonadal shields sit right in front of the X-ray sensor and could actually be resulting in more radiation rather than less, which is the opposite of the intention of shielding and protecting from radiation.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to Frame by Frame, Rethink Imaging. Today, we are joined by Dr. Summer Kaplan, who is an associate professor of clinical radiology at the University of Pennsylvania School of Medicine and a practicing pediatric radiologist at the Children's Hospital of Philadelphia. With over a decade of experience in pediatric imaging and a deep focus on quality improvement, she has become a key voice in advancing safer, smarter imaging practices for children. Dr. Kaplan is also the recipient of a prestigious CAFE Award for her research challenging longstanding assumptions about gonadal shielding in radiology, and that's where we're going to get started today. Dr. Kaplan, welcome to Frame by Frame. Thank you so much for being here.
Thanks, Chris. I'm glad to be here.
Cool. Well, just to kind of set the stage a little bit and get things kicked off with you, I believe it was 2015 study questioned the use of gonadal shielding in pediatric radiology. Can you walk us through what led to that research and kind of what you found?
Sure, yeah. So that was a project I did pretty early in my career. I had developed an interest as a resident my interest goes way back in medical physics and how we acquire the images we acquire. And so as a resident, I got interested in shielding sort of by chance, just reviewing ACR practice guidelines around X-ray. And there wasn't really strong advice about whether shielding was good or not. And I kind of wondered, why don't we know? And discussing it with our physicists and some of my attending faculty at the time, we started to think about the shields and how they interact with the X-ray equipment. And going way back, right? So, I'm going to dive in pretty deep into what we did, why we did what we did. But shields were implemented a long, long time ago in the 1950s. We started shielding in X-ray. And at that time, imaging techniques were much simpler. So X-ray techniques kind of developed in tandem with photography techniques. You can think about it that way. Like you think about how old-fashioned cameras worked. You have to adjust your light meters and you have to adjust your aperture and all these complicated things to take a picture. And X-ray machines worked very similarly. Over time, as technology advanced, as you know now, if you take a picture with a camera, you just click a button or you push a screen and all the light adjustment is done for you by the camera. And X-ray techniques sort of developed similar ways to adjust the amount of light or radiation really coming in. Our current X-ray technology adjusts the amount of radiation that comes in based on a sensor in the X-ray sort of imaging receptor. And when you use a shield, that shield can block the sensor that senses how much light is coming in. And so it occurred to us that gonadal shielding started so long ago when techniques were much different, and now the techniques have changed. It may not make sense to do that anymore.
Right. So if you were trying to I think white balance is a standard adjustment you would make on a home camera, right?
Exactly. Right.
It's if you were trying to white balance your camera with a giant black circle in the middle.
The sensor wants to see a certain threshold amount of light or radiation. And if you put something in front of that sensor, it doesn't see that amount of light. So it'll actually keep exposing longer until it reaches that threshold. So we sort of, reasoned that the shields might actually be contributing to higher doses because they could be blocking that sensor in the X-ray machine. So that's really what's prompted the research that we did, was that idea, that theory that the gonadal shields sit right in front of the X-ray sensor and could actually be resulting in more radiation rather than less, which is the opposite of the intention of shielding and protecting from radiation.
This might sound silly, but are there still machines out there that are being used that don't have these capabilities and where shielding is still...
Yes, that's a great question. Yeah. So there are two ways you might end up with a machine that doesn't have that kind of exposure control. It's called automatic exposure control. There's some ways you might not have that. So one is if you have a very, very old machine, but I think that would be like decades old. So it's not as likely. However, when you're using portable X-ray technique, you don't have that same equipment in the imaging receptor plate. So portable X-rays don't use this dose modulation. It's just based on the technologist studying the technique manually. Yeah, so for portable X-rays, you wouldn't necessarily increase dose by using shields. But in that situation, usually portable X-rays are done for patients who are the most sick, who can't leave their bed.
Mm-hmm.
And in those cases, I think the risk there is actually higher that you would miss something because a shield is in the way. And the radiation sensitivity of the gonads is lower actually than bowel. It's lower than stomach. It's lower than bone marrow. So if you really want to be protective, you should shield the stomach, not the gonads, right? Like you should
Right.
look at the information we have, and nobody's shielding the stomach because that would be weird. Like you need to see things in that area.
Mm-hmm. Right.
I think that, the risks, whether it's radiation or just loss of information to shielding, is not worthwhile. And that difference in radiation sensitivity means that if you do shield gonads over one of these exposure control devices, you're going to increase the radiation, by quite a bit. And you're going to increase it to radiation to organs that are more sensitive, right? Like the colon is more sensitive than the gonads. So if you shield the gonads, you're maybe doubling the dose everywhere else. You're doubling the dose to more sensitive
For those more sensitive tissues.
Yeah,
right.
by shielding the gonads, which are less sensitive. So it's really backwards based on what we know now. It's just, there's so much knowledge out there. There's so much information that it's hard to keep everything updated.
Right. Of course. And so your study was in 2015. Have you seen practices like shifting and changing since y'all came out with that?
Yeah, they really have. They really have. And I think the medical physics community really moved it forward. I mean, we did the research just sort of out of curiosity, but I don't have the kind of political advocacy or the network to make a change like that happen. But the medical physics community really took that up and helped change policies around the country, because there are a lot of policies in place to promote shielding. At the time these policies were put in place, that was thought to be the right thing to do for patient safety, to protect against radiation to the gonads. And so there's laws throughout the country in almost every state that either require or strongly advise gonadal shielding. And so to go against that, we had to really work with regulatory bodies to change those statements. I think any hospital or radiology practice is going to be reluctant to change and before those laws are changed. There's some wiggle room in these laws, that shielding is advised unless a physician thinks it isn't needed. So there's some leeway even in the existing laws that allow people to stop shielding before the laws are changed, because laws do take a long time to change. So so it did really spread, I think, based on promotion through the medical physics community. And then just maybe it was a question that had been on people's minds, that we happened to do the research, but maybe it was just a question that was, people were ready for it.
Right. And the reason for specifically shielding the gonads versus other body parts.
Yeah.
Right. Like, was shielding always gonad specific focus? Were there other like sensitive areas or other body parts where shielding was like super common practice?
For sure. Yeah, for sure. And I think the common areas you would see shielded historically were the gonads, the thyroid, and you still probably have that in dental offices or even other imaging places. And the breasts were shielded sometimes, depending on what body part was being imaged. And that was, initially based on the knowledge we had around radiation risk. So there's a radiation sort of advisory and research body, ICRP, that publishes tables of how radiation sensitive different organs are. And so they base this on a huge amount of research that I couldn't even begin to tell you about, but I just trust their numbers.
Yeah.
So they first came out with these numbers in, I want to say like 1970 something. And at that time, our understanding of radiation was much more limited. So based on what we knew then, the gonads, the thyroid, the breast, these were all very radiation sensitive tissues. And so that's where the shielding really began based on that knowledge.
What were the results of the study? What did the data kind of say?
Yeah. So initially, those data were based on research, but also on like an abundance of caution, because the last thing you want to do is accidentally deliver high doses of radiation to the gonads and leave somebody sterile or risk developing cancer in the gonads, or specifically the gonads, have reproductive potential. And so there's also the risk there that you could create mutations that we pass on to offspring. So other tissues, there's risk of cancer, risk of burns or other things elsewhere, but the gonads specifically, there's, people were concerned about the risk to any reproductive capabilities. So people were extra cautious with radiation around the gonads. And that we found over time, now that it's been 50 years of additional data on what radiation does to the gonads, we have not seen any evidence that there are heritable effects in humans. So yeah, really no, there's no documentation of radiation to the gonads resulting in mutated offspring, as much as comic books would like to make you think that's what radiation does. It doesn't really work that way.
I would love to go in for a CT one day and walk out super, but
right. Become the Incredible Hulk all of a sudden, right?
Yeah, exactly. I mean, I go to the gym. I could deal with a little bit of extra irradiated strength.
Yeah.
So largely the practice of gonadal shielding is largely put to bed, yeah? Or are there scenarios where it's still recommended?
It takes a long time to change practice, especially in a country as big as the United States. And there's so many different practice types, different states. There's a lot of variety. And so for things to really percolate through the whole field takes, I want to say, like a whole generation almost. It really starts with training. So now X-ray technologists and, technologist training programs now are no longer teaching shielding. And I think that's where the core change begins, because, the more technologists who are the ones responsible for placing the shields, the more they understand that this is not actually, it's not actually keeping patients safe. Like we thought it was, there for safety, but it's actually not. And it's maybe more harmful than it is safe. So I think we'll see the field, eventually shift to no shielding, but I'm still, we read x-rays from outside hospitals all the time, and I still see shields coming from smaller hospitals.
Yeah, and what would you say to someone, potentially a patient who's used to shielding, goes to some facility with one of these newer machines and all of a sudden is concerned about not having a shield?
Yeah. I mean, that's a real challenge. And the people who do that explanation typically are the technologists. And so having some talking points for them is really important. I think the key talking points are that we've updated our knowledge. So not only are the machines different now, but our understanding of risk is different. And I mean, this is more detail than I would tell patients, but initially we thought the gonads would bear like a quarter of the risk in a radiation event. Like if you have a whole body radiation event, the gonads were weighted as like a quarter of the risk would be borne in the gonads. And with more data, we know that it's only like 8% actually of the risk is at the gonads. There's other risk elsewhere in the body, in the bowel, in the esophagus, in the breast tissue, in the bones. So the gonads are not as sensitive as we thought. So what I would tell a patient is that our technology has changed, our understanding of risk to the gonads has changed, and it turns out that when you combine shielding in X-ray now, that it actually can result in an increase in dose because of the newer technology. And so we don't want to increase dose in a way that, that we don't need to. And it can also block findings that the radiologists need to see. So there's several reasons not to use it.
Yeah. And so we've touched, a little bit on shielding patients, but I am naturally curious about like staff shielding protocols as well.
Yeah. So that's a great question. And we do get that question a lot, especially from families, even outside of gonadal shielding, just, their child is in this X-ray machine and the child has no shielding on. The parents are wearing lead. The staff is wearing lead, and the parents are like, why is my child left unprotected?
Right.
And everyone else in the room is protected. And there's several reasons for that. So the child is there to benefit from the exam, so that they're receiving benefit from the radiation. the parents are not receiving any benefit from any radiation. There's actually, again, state laws that regulate the lead shielding of people who are not, there to receive a medical procedure or exam. So we're actually required by law to provide shielding for non-patients, non-medical personnel in the room. And that can be either wearing lead aprons, which is most common, or it can be standing behind a lead glass plate or something. So that's required. And it's because the parents don't benefit from any radiation they might receive, whereas the child is benefiting from it. For staff, it's slightly different because they're working in radiation every day. Their exposure levels are just much higher than a patient who comes in, even once a month, for a scan. The staff are being radiated. They're in a radiation field every day. So they wear lead to protect themselves. They also wear dosimetry badges because there's annual limits of radiation that a radiation worker can receive. So staff have to make sure they're not going over those levels. But that's a great question because we do get that question from families.
Oh, yeah. I mean, of course. I feel like getting imaged is something that everyone will run into at some point in their life, right? It's something that we probably expect at some point, but for something that is relatively normalized and something that, I was talking to my friend last night who's a nurse and, he was talking about all the CTs that he's ordering. There was a study recently that came out. We were talking about CTs in general.
We've all heard of that study.
Yes.
Yeah. Interesting. Uh-huh.
He was commenting on the increase in fear around imaging. And so I can't even imagine being a parent, especially with, stories coming out like the ones that are going into a room wearing all that protective gear.
Sure, exactly.
Yeah. And then just having to worry for your kid. You've pretty much covered it already, but would there be anything else that you would add, if talking to a family in these situations?
For children, we use extremely low levels of radiation. And the amount of radiation that you use for a patient is relative to their body size. So a 1-month-old infant is going to get a tiny fraction of the radiation that an adult would get for the same exam because they're just so small. So we're using very, very small doses in children anyways. Diagnostic imaging uses extremely low levels of radiation compared to therapeutic radiation like you might have for oncology or even interventional, where you're doing procedures to repair vessels and things like that. So the diagnostic imaging, which is what most people are going to encounter, is very low. Even for CT, I mean, a CT is generally maybe 100 times, 10 to 100 times more than an X-ray. And even those levels are relatively low. We think of kind of a risk-benefit ratio. When you're getting an imaging exam, you should be getting some benefit from that exam. And, that's kind of the other side of these discussions about radiation and how dangerous it is. I mean, there's also a lot of benefit to it, and that's why we use it.
That's kind of where I was about to go with it too, right? It's yes, there is some potentially quantifiable level of risk associated with it, but compared to the risk of not finding out
exactly
the problem that has them in that X-ray, in that CT.
Exactly. Yeah, you think about these prediction models of, maybe, 100,000 people will die of cancer from, a certain number of CT scans, but also those 100,000 people didn't die of an aneurysm. They didn't die of a renal infection.
Yes.
They didn't die of the things that CT prevents you from dying from because we catch things.
I was just talking with Dr. Sumay at Duke about this on an episode. And what I was saying to him is, I was just well, yeah, if it means I get to live to see myself get cancer at 60, yeah, I'm probably going to get imaged.
Yeah, that's great. And I think that part of the story gets overlooked because it's so sensational to think about. Radiation's invisible. It's scary. We don't know. It kind of sneaks up on you. You don't really, it's just kind of scary and it's sensational. So people like these stories, but there's the other side to the story, which is that it's very helpful.
Yeah, for sure. And so are there other, in terms of the journey of shielding throughout the country, I know you were saying, it's a slow regulatory process, guidelines change slowly. What kind of where are you seeing this breakdown? Is it larger facilities versus smaller? Is it more urban versus more rural? It's different by state?
Yeah. So I don't have a lot of personal experience with that kind of variety, but I think like where I have seen it move forward the most quickly and the most effectively is where there's an advocate for it. Like it could be a large hospital system that has a champion who wants to put the work in to change policies, but it could also be a small hospital. It's really kind of person to person dependent at this point until training really changes and people understand not to use it. So it could take 10 years for it to completely go away. I mean, maybe if companies stopped selling the shields, I don't know. I don't know. Maybe that would help.
In terms of legislation, is there a big difference between pediatrics and adults?
No, the legislation is not specific for children or adults. A lot of the research has been done in children, and I'm not sure exactly why, other than that people are most concerned about radiating the gonads in children because of the lifelong reproductive capabilities. In practice, there isn't a lot of difference in policies. Shouldn't be.
Yeah. Do you have any other points on peds specifically that you'd like to get into?
In pediatrics, it's really the parents are there looking out for the parents, the guardians, whoever is there looking out for the child. And so there's a lot more concern. Whereas I think an adult, part of becoming an adult is just giving into things you don't understand.
Right. Yeah.
So I think adults just will get the exam. Sometimes people are, really anxious about it. And there are higher risks associated with radiation use in children because the dangers of radiation are their effects on dividing cells, which is why you see gut and bone marrow are highly sensitive because there's a lot of dividing cells, a lot of replacement of, gut lining as it comes back off. So children obviously growing lots of dividing cells. And so that's one reason why we're more cautious with radiation in children. And then also, they should have a longer lifespan over which to develop, any radiation-induced cancers. So for those reasons, we're a little bit more cautious about radiation in children. And I think when it comes to gonadal shielding, it's really the concern on the part of the family, the guardians, in terms of what does this mean for the child? Because everyone there wants to keep the child safe, keep the patient safe. That's the goal of the guardian, the parents, that's the goal of the staff, that's the goal of everyone, is to keep the child safe. And we just need to understand how we're doing that, I guess.
Yeah, for sure. Slightly tangenting, but do you have any advice for potentially a listener of this show or anyone working in radiology departments who are still using outdated shielding practices? What are steps that they could take?
Sure. There's plenty of evidence now, through research and through policy that gonadal shielding is not recommended anymore. So that comes from, professional organizations like the American Association for Physicists in Medicine. It comes from the American College of Radiology, but it also comes from national regulatory bodies or advisory bodies like the National Council for Radiation Protection, NCRP, which most people outside of radiation nerds have never heard of before. But it also comes from the FDA, which most people have heard of. The FDA no longer recommends shielding. And for for the radiation tech, the X-ray technologists, their societies also have come out against shielding. So I think if anybody is unsure about whether they can stop, I think the evidence and the policy backs you stopping it. The difficult thing in practice is how to communicate that to your patients, to your families. And the NCRP actually does have some guidelines on how to communicate and some flyers that are written for patient understanding, not for medical people. So those are a good resource. NCRP, gonadal shielding information that people can use to help train their technologists how to have these conversations.
Yeah, I've seen some of the numbers. I know how busy imaging departments are these days and how understaffed they are. There's a lot to do, an infinite amount to do and an infinite amount of information to keep up with, right? The technology is getting better every day. There's new regulations. It's just constant.
Yeah, it really is. Yeah, it's a lot.
Speaking of technologies improving, are there other emerging technologies or protocols that you see or interact with regularly that could, further reduce radiation exposure, especially in pediatrics?
Definitely. So I think there's a couple ways to think about it. One is, in how we acquire the images. So pretty much every vendor who sells imaging equipment improves their photon capture, improves their imaging technologies each time they bring out a new machine. So, for hospitals that can afford it, keeping your machines updated is a great way to reduce radiation. So the detectors are more sensitive with each generation. The image reconstruction algorithms are much better with each generation. So that's the most expensive and most effective way to improve your image quality and decrease your radiation. I mean, the other thing that I am very interested in is selecting who needs to get exams, who needs to get radiation exams. And that's where I think things like predictive AI and machine learning, like these artificial intelligence tools, can help us better understand who benefits from imaging.
Mm-hmm.
So that we're really, I mean, it's always said that the lowest radiation study is the one you don't do. So not
Right.
doing studies that don't provide a lot of benefit is good for the patient and good for the healthcare economy, good for, people saving money on their healthcare. So predicting who would benefit most from imaging is something that would be fantastic, but I think that's a long way off.
That's so interesting. At Imalogics, obviously, we're using, machine learning to help folks with, things like patient centering and stuff, and using AI to do that. But like, you're literally talking about using AI to, to put in like a bunch of bodily markers, perhaps, and like predictively say this person should get imaged.
Yeah, I mean, I think you're never going to have a machine that's going to say, yes, no, you should or shouldn't be imaged, but just a likelihood. What's the likelihood you have appendicitis based on your symptoms, your history, your things like that. I mean, it's what doctors do anyways. We take all the information and we come up with a probability of what we think is going on. And like I said, there's so much information out there, not just in the literature and in research, but in the patient charts. That it's really hard to take all of that into account. And so I think having tools that pull all that together for us a little better would be fantastic.
Yeah. And are there specific like biomarkers or like data? What are these theoretical AIs like actually looking at when determining like, yes, this person should be imaged in X number of years or something?
Yeah, I don't know. I think you'd have to look at it's all probabilities and statistics. You'd have to look at, the features that the patient is coming in, complaining of. Is it fever? Is it chest pain? Is it short of breath? So you're more likely to have a pneumonia than like a knee infection. Like that's an obvious example of how you take information and you make a prediction, but using the more information you have, the better you can predict. So using more of the information in the charts to help us understand where imaging benefits people would be interesting.
It's very Star Trek, right? Like just like full body scan, like, okay, here's what you need to be worried about.
Yeah. It's interesting. People think they want to know what's in their body, but there's a lot of things going on in there.
Oh
You maybe
God, I
don't
do
want to know.
not. I remember when all the DNA testing labs were popping up all
Oh
over the
yeah.
internet. I was just like, no, I don't want to know. I don't need to.
And that's the thing with radiation risk is I think it's very person specific, just like a lot of, disease is. We saw during I'm going on a complete tangent now, but we saw during the
No,
COVID
it's okay.
pandemic, like it affected people so differently. Some
Oh
people
my
got it and
gosh.
didn't even know they had it. Some people died of it. And so it's, every human is built completely differently and it's hard to predict, what something is going to do to somebody. And I think with radiation, it's the same way. Some people might be very sensitive to those kind of DNA breaks that get, that are caused by radiation, and some people might not be. And you just don't know which of those you are or which of those your patient is. We don't have a way to understand that yet. So that would be nice for people who are getting imaging for themselves or for their children. I just hope that they understand that the medical staff are all it's their like primary job to keep patients safe. And so we would never recommend anything for patients that we know to be harmful. So changing gonadal shielding practices can seem scary to people, especially if they've been in the hospital or been, encountered radiology and are used to shielding, but our knowledge is updated. And so we're updating our practices. It's also important to understand that the levels of radiation and the levels of risk with diagnostic imaging are so low. So it doesn't mean that because you were shielded or your child was shielded a month ago when they came in that they were harmed by that shielding. The doses are very, very low. And so doing away with shielding is just following the, as low as reasonably achievable principle. So that's kind of a guiding principle in radiology. We don't really know how radiation is going to affect any one person or even a population because it's such a long time between any exposure and any fallout or anything that could happen from that exposure. We really don't know. There's no cause and effect kind of understanding. And so the risks are very, very low. Yeah, it doesn't mean that you were harmed by shielding in the past. It just means that we now know that, it's better to not shield. And so we've changed our practices.
There's so many things in daily life, right? That you learn, you adapt, and you change your habit.
Right.
I was going to bring up seatbelts, but that's a terrible example in this context. But
yeah, we used to not wear seatbelts, and now we do, all kinds of crazy things we used to do in medicine, right? Like doctors would write prescriptions for cocaine because that was thought to help. And now we don't do that anymore.
I think I used to live in New Orleans, which has a pharmacy museum. And I think I remember seeing at the pharmacy museum, obviously there's the one section of just heroin, cocaine, opium, all of these things prescribed with the doctor's label.
Right.
And my favorite one, I think, was a pack of cigarettes labeled for asthma.
Right. That's wild. Yeah. So we have to be updating our knowledge. We can't just keep doing what we've always been doing.
The status quo is not necessarily best practices.
Yeah. It should be updated.
Well, great. Dr. Kaplan, thank you so much for joining us today on Frame by Frame. I really appreciate you being here.
Thank you. It's been great. Thanks for the conversation. And I hope this is helpful for people.
Yeah, absolutely. Thank you for helping get the word out, too. Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.